Now let's study about the protective factors that play a role in protection of PID. The protective factors are contraceptive practice. In contraceptive practice, there are barrier methods. So these will protect from the STDs. OCPs, how OCPs are prevented? First will be they will produce thick mucus. So this will prevent the ascent of the bacterial penetration. Next, they decrease the duration of menses. So this will create a short interval of bacterial colonization. And next is monogamy, or having a partner who had undergone vasectomy. And others is pregnancy, menopause, and vaccines like hepatitis B and human papillomavirus. If we see the microbiology of PID, then PID is polymicrobial. The primary organisms that are causing PID are the sexually transmitted organisms, and in this 30% are Neisseria gonorrhoeae, 30% are Chlamydia trachomatis, and 10% are Mycoplasma hominis. The secondary organisms are the organisms that are normally found in the vagina. These are aerobic and anaerobic organisms. Aerobic organism, E. coli, staph, group B, streptococcus, non-hemolytic streptococcus. In anaerobic, we have studied about the bacteroids, and in bacteroids, fragilis. Next can be peptococcus and streptococcus. What are the mode of infections of PID? We have already studied about the 5 modes First is the continuity and contiguity through which the gonococci is spread. Next is the reflux of menstrual blood. Next is through parametrium or through peritoneum. Next is through lymphatics. And next is through gut. So gonococcus through mucosal continuity and contiguity. Next is gonococci can also be spread through reflux of menstrual blood into fallopian tubes. Next is through parametrium. And the secondary organisms spread through lymphatics and the organism can directly spread from gut also, and this is rare. Now let's study about the pathology of PID. So the pathology started in endosalpinx. How? There will be gross destruction of epithelium, cilia, and microvilli. And if there is severe infection, then this infection may invade all the layers of the tube, and the tube will become edematous and hyperemic, and these exfoliated cells along with the exudate, they will collect in the lumen of the tube and agglutinate in the mucosal folds, and this will result into the closure of abdominal ostium, which will result in edematous fimbriae, indrawing, and inflammatory adhesions. And the uterine ant will be closed by congestion. Now so this is the fallopian tube. The uterine ant is closed due to congestion. The abdominal ostia is closed due to the exudates, agglutination in the mucosal folds. So the infection will collect here, and due to the collection of this infection, the infection will pent up inside the tube. And depending upon the virulence, the exudate can be watery or purulent. If it is watery, then it is hydrosalpinx, and if it is purulent, then it is biosalpinx. Okay. And if the exudate is purulent, it is more dangerous because it favors growth of other pyogenic bacteria, which will result in deeper penetration of tube and more tissue destruction, and the organism generally spontaneously dies in 2 to 3 weeks. As we know that the serous coat is not so much affected, so the adhesions will be not that dense. In fact, they will be flimsy. But as we have in serous, but in pyogenic and tubercular infection, the adhesions will be very dense. And on occasions, these exudates can pour through the abdominal ostia, and it will cause the pelvic peritonitis, and it will result in pelvic abscess. Or it can affect the ovary also, so it can be ovarian abscess. So this is tubo-ovarian abscess. What are the clinical features of PID? So first thing is that these symptoms are non-specific, and next thing is these symptoms will arrive as soon as the menstruations are stopped, as soon as after the menstruation. So there will be bilateral, so this is the abdomen, this is the pelvis. So there will be bilateral abdominal pain and pelvic pain that will be dull in nature. And if it is gonococcal infection, the pain will be more acute as compared to the chlamydial infection. And as there is infection, so fever will be present, lassitude will be present, headache will be present. And if there is irregular and excessive vaginal discharge or vaginal bleeding, that may be due to associated endometritis. And there can be abnormal vaginal discharge also, which will be purulent or copious. There will be associated nausea, vomiting, dyspareunia. Dyspareunia is pain during sex, pain and discomfort in the right hypochondrium due to concomitant perihepatitis. This is known as Fitz-Hugh-Curtis syndrome. And why it is occur? If due to, as we have know that there is peritoneal involvement due to the leakage of the exudate through the abdominal ostia due to transperitoneal or of either gonococcal or chlamydal infection. What are the signs? So these are important. What are the signs of PID? First is that the temperature will be more than 38.3 degrees centigrade. If we will palpate the abdomen, there will be tenderness in both the quadrants of lower abdomen, and the liver may be enlarged and tender. On vaginal examination, there will be abnormal vaginal discharge which will be purulent. There will be congested external urethral meatus or openings of Bartholin ducts through which pus can be escaping out. On speculum examination, congested cervix will be present and purulent discharge from the canal. On bimanual examination, there will be bilateral tenderness on fornix palpation, which will increase more with the movement of cervix, and there will be thickening or a definite mass that will be felt through the fornices. So there will be tenderness present in all the areas that we can palpate, in the vagina, in the cervix, in the fornices, in the Bartholian gland, in the duct. So there will be purulent discharge from the Bartholian gland, from the vagina, from the cervicovaginal canal, and there will be temperature that will be reached more than 38.3 degrees centigrade. Next, we will study about the clinical diagnostic criteria of PID. So there are three criterias. First is minimum criteria. In minimum criteria, there will be lower abdomen tenderness, there will be adnexal tenderness. Adnexal tenderness means this is uterus, this is cervix, this is vagina. Okay, so there will be tenderness of the adnexa, there will be tenderness on cervical motion. Next is additional criteria. What is additional criteria? That the oral temperature should be more than 38.3 degrees centigrade, and there is mucopurulent cervical or vaginal discharge. There is raised C-reactive protein, or there is raised ESR, and laboratory proven positive cervical infection with chlamydia and gonorrhea. What is the definitive criteria? Definitive criteria is histopathologic evidence of endometritis on biopsy. Next is imaging study. What are the imaging study? Transvaginal sonography or MRI. What we will see in this, that there is thickened fluid filled tubes with or not tubo-ovarian complex. And next is laparoscopic evidence of PID. What are the investigations that are used in? First is identification of organism. How will identify the organism? So we will first have to collect the sample. From where we will collect the sample? So from three regions we can collect the sample. First is from the urethra or from the Bartholin glands, from cervical canal, or we can collect it from the fallopian tubes during laparoscopy or laparotomy. And the material, the sample that we have collected, we will send it for gram staining and culture. If the result come as gram negative diplococci, that means there is gonococcal infection. And one thing that have to be noted, that diagnosis of clostridium trachomatis is very difficult, so we give the prophylaxis for clostridium trachomatis as soon as we have discovered that the patient is having PID. We can send the blood samples also, and in blood samples, if there is elevated ESR and the leukocyte counts are raised more than 10,000 and the ESR is raised more than 15 per hour, that means there are some inflammatory reactions that are taking place in the body. And if we are suspecting that the case is of a syphilis, then we will do the serological test for both partners, both male and female partners. We can do the laparoscopy, and the laparoscopy is the gold standard for the PID because it is the most reliable aid to support clinical diagnosis, but it is not feasible in all cases. We know we can't do laparoscopy in every patient, so it is reserved in those cases in which we have to differentially diagnose the salpingitis, appendicitis, or ectopic pregnancy. Okay, so three cases for which we can do the laparoscopy. It is salpingitis, appendicitis, and ectopic pregnancy. What are the laparoscopic findings and severity of PID? So the mild PID means that on laparoscopy the tubes will appear edematous, and there will be no purulent exudates, and the tubes will be mobile. In moderate severity of PID, the purulent exudates from the femoral ends and the tubes will not be freely movable, and in severe there will be pyosalpinx, inflammatory complex will be formed, and there will be inflammatory complex, that is tubo-ovarian complex, and there will be abscess present. What are the Violence rings? Violence rings are the adhesions in the pelvis and around the liver, which suggests that there is chlamydial infection. So Violence rings are present in chlamydial infection. These are the adhesions that are present in the pelvis and around the liver. Okay, and in laparoscopy we can aspirate the fluid or pus from the fallopian tube and from the ovary or pouch of Douglas, and we can send it for the microbiology test. Next, we can do the sonography. It is of the limited value. Why? First thing is how we can diagnose that there is PID. In PID, the tubes, fallopian tubes will be appeared as dilated and fluid filled, and there can be fluid present in the pouch of Douglas or adnexal mass that are suggestive of PID. Next, we can do cludocentesis. What is this? In this, we will aspirate the peritoneal fluid and we will do the white cell count if it exceeds the 30,000 per ml. If in the peritoneal fluid the WBC count is exceeded 30,000 per ml, that means that there is PID present. Bacterial culture from the fluid is not informative because of vaginal contamination. Investigation also to be extended to male partner, and smear and culture are made from urethral secretion. So if we have to do the investigation in male, so the sample taken will be the urethral secretion. Now how we can do the diagnosis? For the diagnosis, first thing is we will do the anatomic diagnosis of infection. How we can do the anatomic diagnosis? In anatomic diagnosis, the same thing, that there will be discharge from the vagina, from the cervix, there will be tenderness present, there will be fever, there will be deep dyspareunia, there will be cervical motion tenderness or adnexal tenderness. Next is we can do the microbial diagnosis, which is very difficult, and we know that the samples which are taken are the cervical and urethral discharge from the Bartholin's gland, laparoscopic or laparotomy collection of the pus from the fallopian tubes, and these are sent for the gram stain and culture. Gram stain, if there is gram negative diplococci, that means that is Neisseria gonorrhoeae, and if the woman has a stable sexual relationship with asymptomatic man, then the clinical manifestations are unlikely to be due to chlamydial infections. So chlamydial infections, we know that is due to that is sexually transmitted disease. So if the male partner is completely normal, that means that is not the case of chlamydial infection. What are the differential diagnosis of the PID? So that is appendicitis and disturbed ectopic pregnancy. So this is all about some other conditions that also mimic the PID: urinary tract infections, diverticulitis, endometriosis, torsion of ovarian pedicle, hemorrhage or rupture of ovarian cyst. The two conditions like acute appendicitis and disturbed ectopic pregnancy must be ruled out, because these both conditions require urgent laparotomy, and whereas acute salpingitis can be treated conservatively. What are the complications of PID? The complication of PID, as we know, that if the abdominal ostia, from the abdominal ostia, if the exudate released into the peritoneum, there will be pelvic peritonitis or even generalized peritonitis. There can be septicemia, which can produce the arthritis or myocarditis. So these are the immediate complications of the PID. What are the late complications? So the late complications will be the dyspareunia. Infertility rate will be 12%. After 2 episodes, it will be 25%, and after 3, it will be 50%. And why it is so? Why there is infertility in PID cases? Because there will be damage of the fallopian tube or tubo-ovarian mass. This can result in chronic pelvic inflammation. There can be formation of adhesions or hydrosalpinx or pyosalpinx and tubo-ovarian abscess. So these are the late complications that are of the PID. There can be chronic pelvic pain and ill health, increased risk of ectopic pregnancies 6 to 10 fold. So, main late complications are that the infertility rate are raised due to PID, and if the PID is having one episode, then the infertility rate will be 12%. If there are two episodes of PID, then it will be 25%. And if there are three episodes of PID, then the infertility rate will rise to 50%. And the next is that there is increased risk of ectopic pregnancy. So, what is the treatment of PID? The treatment of PID is, first we will do the prevention. How we can prevent PID in community? So first we will do that we can aware the community awareness. Next we can do that we give knowledge about healthy and safer sex, so we can avoid the spread of the sexually transmitted diseases. Liberal use of contraceptives, and routine screening of high risk population. What are the principles of therapy? The principles of therapy is, first we can control the infection, second is we can prevent the infertility and the sequels, and third is that we can prevent the reinfection. So these are the three main principles of the therapy. What we can give in the outpatient therapy? Outpatient therapy means the therapy we can give in the OPDs. And as we know that the infection is polymicrobial in nature, so we will recommend the combination of antibiotics. So what combination of antibiotics we give? So first thing is that this treatment goes for 14 days for PID, and we can give two regimen A and regimen B. In regimen A, we are giving levofloxacin and metronidazole. And in regimen B, we are giving three drugs: ceftriaxone, doxycycline, and metronidazole. So metronidazole is given in both the regimen. Levofloxacin is 500 mg per oral once daily, with or without metronidazole, and metronidazole is 500 mg per oral BD. Let's talk about the regimen B. Then ceftriaxone is given as 250 mg intramuscular single dose plus doxycycline 100 mg per oral BD, with or without metronidazole 500 mg per oral BD. And we can also use the broad spectrum antibiotic like cefotaxime or cefoxitin. and we evaluate the patients for 48 hours. If after 48 hours there is no relief in the symptoms, then we will hospitalize the patient. What are the inpatient therapy? What are the indications for hospitalization? One is that there is tubo-ovarian abscess. Next is there is severe illness, there is vomiting, there is temperature more than 38 degrees centigrade, patient who is unresponsive to oral therapy which we have given in outpatient therapy, or the patient which are intolerant to the oral antibiotics, if the patient is having pregnancy, or the patient is a known case of HIV infection. So these are the some situations in which we will hospitalize the patient. In inpatient therapy, we will give the antibiotic therapy. First thing is we will do the bed rest, give the bed rest to the patient. Oral feeding will be restricted. If the patient is dehydrated or acidosis is present, so we will give the IV fluids. We will give the IV antibiotics for at least 48 hours, and it can be extended to 4 days if necessary. How we can say that the patient is improving? If the patient temperature is remitting, improvement of pelvic tenderness and normal WBC count, and negative test for bacteriological studies. So what are the inpatient antibiotic therapies? So there are 3 regimes: regimen A, that we will use cefoxitin 2 gram IV 6 hourly for 2 to 4 days, plus doxycycline 100 mg per oral for 14 days. Next is regimen B. Regimen B is clindamycin 900 mg IV every 8 hours, plus gentamicin 2 mg per kg IV, that is the loading dose, and then we will give the 1.5 mg per kg, that is the maintenance dose, every 8 hours. What is the alternative regime? Alternative regime is levofloxacin 500 mg IV once daily, or metronidazole 500 mg IV every 8 hours. What are the indications of surgery? The indications of surgery are generalized peritonitis, pelvic abscess, tubo-ovarian abscess. And to prevent reinfection, we can educate the patient to avoid reinfection and the potential hazards of it. The patient should be warned against multiple sexual partners to use condoms if the sexual partner or partner to be traced and properly investigate to find out the organism. And if they have got non-coccal urethritis, then it will be treated with. If the partner is having non gonococcal urethritis, then we will treat it with tetracycline 500 mg 6 hourly or doxycycline 100 mg BD daily for 7 days. How will follow up? For follow up, we will repeat the smears and cultures of the discharge after 7 days after the full course of treatment, and the tests are repeated following each menstrual period until it becomes negative for 3 consecutive reports. Until she is cured and her sexual partners have been treated and cured, the patient